These are basically metabolic bone diseases, which are characterized by increased amount of unmineralized osteoid, unmineralized bone, and a decrease in the rate of bone formation. If we talk about rickets, so it is basically the form of osteomalacia which develops in children before the epiphyseal closure of the bones, and this condition is characterized by defect in maturation. Means defective maturation as well as the mineralization of growing skeleton. And when we talk about the osteomalacia, it is characterized by defective bone mineralization, bone pain, muscle weakness, and pathological fracture, which usually is seen in adults. So, before moving forward, first of all, I would like to elaborate its pathogenesis. So, rickets and osteomalacia share the same pathogenesis. They both develop due to the vitamin D deficiency, which usually result due to reduced dietary intake of vitamin D or malabsorption or reduced sunlight exposure. Then the low levels of circulating 25 hydroxy vitamin D cause reduced production of the biologically active metabolite 125 dihydroxy vitamin D by the kidney, and this causes a reduction in calcium absorption from the intestine. As we know that vitamin D is responsible for the intestinal absorption of calcium and phosphorus. So the deficiency in vitamin D ultimately cause a reduction in the calcium absorption from the intestine. This low calcium absorption, which ultimately lead to the low calcium serum level, and this triggers or stimulates the parathyroid hormone secretion. The parathyroid hormone secretion basically restores the serum calcium level towards normal, and this hormone do so by increasing the bone resorption. It takes calcium from the bones to normalize the serum calcium level, and the renal tubule as well as parathyroid hormone cause calcium reabsorption from renal tubules. So the high levels of parathyroid hormone also promote phosphaturia that also causes phosphate deficiency. Same likewise, it is the combination of calcium loss from the bone and the phosphate depletion. Calcium loss from the bones due to normalize the serum calcium level, and the phosphate depletion occur due to the renal excretion of phosphate. And these both scenarios collectively causes the impaired mineralization of the bone. So it is the pathology or pathogenesis both of crickets and osteomalacia. We can summarize the causes of osteomalacia and rickets as it may be caused by vitamin disorders, which includes vitamin D deficiency. It may be the vitamin D deficiency can be due to the decreased availability of vitamin D in diet or insufficient sunlight exposure, and the third one is the malabsorption of the vitamin D. Or if there is adequate amount of dietary vitamin D, if sufficient sunlight exposure, and there is no case of malabsorption, it is then the pathology can occur in the later stages at the level of conversion of 25 hydroxy vitamin D to the 125 dihydroxy cholecalciferol, and this impaired conversion may be due to the chronic renal failure, as the kidney is responsible for the activation of the vitamin D. And if the conversion is doing as per physiological processes normally, and but the receptor defect can cause the vitamin D dependent rickets or osteomalacia, and basically it is the autosomal recessive disease. Other causes may include the dietary calcium deficiency and phosphate deficiency, and these both could be due to the decreased intestinal absorption or due to nutritional deficiency or malabsorption. And other bone metric disorder can also lead to the osteomalacia or rickets. One of them is the fibrogenesis imperfecta. In this condition, the collagen synthesis is impaired, which is needed for the formation of bone. As we know, the organic part of bone is made up of collagen. And the other one is hypophosphatasia. It is the process which is defect process of mineralization. Mineralization not not occur normally in that case. So then, if we talk about the clinical features of rickets and osteomalacia, so in rickets, there may be patient may complain of bone pain, reduction in the growth, and as we know, rickets usually occur in the children. So there may be reduction in growth due to the bowing of the long bones are characteristics of the rickets, with bossing or of the frontal and parietal bones. As these bones get bigger and frontal and the parietal bones of the skull and swelling of the costochondral junction, which are basically the junction between the ribs and the costal cartilage. So it is these are the clinical features of rickets, and this can be diagnosed by the X-rays, as the X-ray shows a widening of the growth plate with a cupped or a raised metaphysis. And if we talk about the clinical features of the osteomalacia, so it is characterized by bone pain, tenderness, skeletal deformity, and the proximal myopathy, which later on results in a waddling gait or in difficulty in climbing upstairs or getting out of the chair. So the bone and the muscular tenderness on pressure is also common, and focal bone pain may occur in association with the fractures may also occur, and usually the sites are ribs and the pelvis. And the osteomalacia can be diagnosed by the X-rays. On X-ray, X-ray basically show the typical pseudo fractures in the ribs, and these fractures are called loser zones. Loser zones are usually occur in the long bones and pelvis. If I define what are the loser zone, these are basically the linear areas of the low density. So that's why they appear less white on the X-ray and surrounded by the sclerotic borders. Other investigations are the biochemical investigation, which include which results the low plasma calcium and phosphate and low vitamin D3 levels, and also low urine calcium level. As to this is because due to the effort to normalize the serum calcium level, the calcium excretion from the kidneys stopped. That's why there is a low urine calcium, and alkaline phosphate is raised in case of fractures. And the third one investigation is the bone biopsy, which is usually not required in that case. However, it is diagnostic of osteomalacia, presenting as a significant unmineralized bone. If I talk about the management of these both of conditions, so as we know, we have to treat the cause, which is the vitamin deficiency, vitamin D deficiency, and the phosphate deficiency and calcium deficiency. So the vitamin D supplements and the are given to the patients, and calcium carbonate is also given to the patient for due to cure the phosphate deficiency. We have to improve the nutrition of the patient, and also give oral phosphate supplements along with the vitamin D supplements. And growth hormones are also given to the patient who has the cause phosphate who has the human recombinant growth hormone reduces the phosphaturia, so that could be added in the above mentioned already mentioned drugs. And we also give patient the Bonex and the Bonex D, which are the compound medicine of the nutrifactor. And Hymont also offer the osmin D3, which is also given to the patient to cure its vitamin D and deficiency. So that was all about the rickets and the osteomalacia. Thank you.